Good afternoon. Thank you for joining us today as we describe Time to Ask, education that transforms conversations around alcohol use. I'm Dr. Stephanie Nichols, and I'm pleased to co-present today with Denise O'Connell and Dr. Mark Publicker. So here we are in a virtual conference. COVID has changed everything for us all. As members of the interprofessional care team, your job duties and method of work may have changed overnight. We had to switch in a heartbeat to virtual visits and telemedicine. We had to learn new systems in a crisis, and we still had to be there on a daily basis, providing care and compassion to our patients. It was hard and really emphasized the importance of a strong skill set in the art of meaningful conversations. It was tough for our patients too, who had their lives thrown for a loop. Anecdotally, many people describe social isolation, increased anxiety and loneliness, and some turn to drinking as a coping mechanism. Now, data shows us that alcohol sales have increased as a result of COVID, and alcohol-related hospital admissions and ED visits are rising too. So by the end of this talk today, I hope that we are all able to examine the potential individual and public health risks and consequences associated with unhealthy alcohol use and the cost of doing nothing. Summarize the benefits and value for patients, families, and the team when interprofessional care members engage in meaningful conversations around alcohol use, and apply evidence-based best practice approaches and tools to address unhealthy alcohol use and promote positive health outcomes. So why alcohol? Why Maine? And why primary care? Well, there's a high rate of morbidity and mortality with alcohol use. Alcohol is the third leading cause of preventable death in the US and the #1 substance of misuse in Maine. Ignoring this public health problem can lead to more costly care. Alcohol screening is the most effective strategy to address unhealthy alcohol use, but our learning needs assessment revealed that most healthcare professionals lack the knowledge, skills, and attitude to provide regular screening and monitoring of alcohol use within primary care practices. The Time to Ask program was designed and built to meet this identified education need. Oops, excuse me. So what comes to mind for you if you were asked to picture someone with an alcohol use disorder? Let's just close our eyes for a minute and picture someone with an alcohol use disorder. Who do you see? Okay, let's open back up. Welcome back. So you may have pictured a person from one specific age group, and perhaps this is who you associate at-risk drinking with. Remember that unhealthy alcohol use can occur in people of any age, including preteens, adolescents, and elderly patients. We know that initiation of drinking before the age of 13 or 14 years greatly increases the risk of development of alcohol use disorder. There's a strong party culture in colleges and workplaces for young adults and middle-aged adults alike. Office beer and Friday office wine parties are becoming common, and after-work drinks are the norm in many settings. Retirement communities have social events that often feature or even center around alcohol and can result in near daily drinking for many residents. I also want to mention that those transitioning in life are at particular risk of unhealthy alcohol use, including those experiencing a divorce, a new marriage, a new baby or other aged child, and there's a whole culture around mommy juice in particular, those who are entering a new job or who had a loss of a job, those who are experiencing a death of a loved one or illness of themselves or loved ones, and even those in other transitions of life, such as a gender transition. Preventing and identifying unhealthy alcohol use across the age continuum can intercept a potential health problem before it escalates, which avoids placing the person and the wider community at risk by requiring costly and lengthy healthcare interventions. So we already talked about the mortality risk with alcohol and it being the third leading cause of preventable death. This translates to 95,000 Americans dying from alcohol-related causes every year, And this number is increasing. So that's the most recent update that we have is 95,000 Americans dying from alcohol-related causes every year and increasing. Well, opioid overdoses are increasing and 88,000 people died of an overdose death last year. This number is still eclipsed by the number of people we continue to lose every year secondary to alcohol. Concerningly, less than 6% of referrals to addiction treatment come from healthcare professionals, and fewer than 10% of Americans who meet criteria for alcohol use disorder actually receive treatment. We have work left to do. So at the request of our first pilot site, this poster was developed by Lunder Deneen to depict the far-reaching effects of alcohol across the body to be used in exam rooms and in waiting rooms. It's an example of one tool developed to engage all stakeholders in learning more about the impact of unhealthy alcohol use. Further on in our presentation, examples of other tools will be discussed. The takeaway message of the poster is that unhealthy alcohol use has far-reaching negative consequences affecting all body systems, and in particular, including the risk of cancer. And there is no lack of scientific data to back up the risks associated with alcohol use. How often do we consider alcohol and the incidence of cancer? How many people know that alcohol is a class level 1 carcinogen? It is clear in the scientific literature that alcohol contributes to overall cancer burden, including breast, esophageal, stomach, and pancreatic cancers. And there is a movement to think more about the use of alcohol in primary care. Here's a sampling of the articles recently published addressing today's topic. So let's talk about that last one there, the elephant in the room. How often have we perhaps suspected or been concerned that our patient's health status may be negatively impacted by unhealthy alcohol use, but have not already addressed this concern? In a moment, we'll do a ready, set, chat. I will invite you to type your response to the questions in the chat, but ask you to not hit enter until I prompt you. I will say when it is time to hit enter. This process is to allow for thinkers of all types, including crock-pot and microwave thinkers, to have an equal playing field at responding to the prompt. I now invite you to take a moment to type your answer to either of the following questions in the chat, but please don't hit enter quite yet. You'll have 1 minute. And so the questions are, why do you think care providers may not explore the issue of unhealthy alcohol use with patients? And what are the barriers you perceive to asking this question? So you'll have just under a minute to answer those questions in the chat, and then we'll invite contributions verbally as you're able and willing. Okay, ready, set, chat. Please hit enter at this time. And let's read the wealth of information that we can provide to each other. I can't see the chat box. I wonder if anyone has any other answers to this question that you want to unmute and bring up for the group discussion. So why do you think care providers, oh, sorry, go ahead.
No, I can just chime in. I mean, I'm not a care provider. Actually come from banking, so I'm more on the patient side. So the perspective that I have is maybe my primary care provider just doesn't fully understand what the impact is.
Yeah, I think that's a really important barrier or reason why people may not be exploring the issue of unhealthy alcohol use with their patients. Absolutely.
Stephanie, I don't know if it would be helpful for me to offer some of what we found at this point.
Absolutely, yes.
We'll talk about it in a few minutes, but we conducted a pre-program needs assessment of all of our program sites. And we also looked at the literature, and what we know is that even in medical school, most health professionals have this much training on substance use, hence why we have this program. And so that just makes folks feel really uncomfortable, feeling like, I don't know anything about it anyway. And then that was another thing that bubbled up when we did our needs assessment, is folks said, I don't feel like there's anything I can do for them. Maybe refer out, and everyone's going to need an intensive treatment program, which we don't have in our state. So those were some of the things. And then the other thing is people felt like they might be insulting their patients, and their patients might think less of them. So those were,
Interesting.
yep. Mm-hmm.
Thank you, Denise. Those are some really important barriers that you brought up. And so we are confident that our program today will help address many of these barriers that Frank listed and Denise that you just listed as well. So oftentimes questions arise when routine screening for alcohol use is proposed in the primary care setting. You may have heard or expressed some of these questions yourself, including those regarding return on investment. Let's do another ready, set, chat. Or we'll just, you know what, instead, let's just do it. We'll have contributions. So I invite you at this point to unmute and answer as soon as I ask the question. So we'll take a few seconds to reflect on, is there a return on investment when patients are screened for unhealthy alcohol use in the primary care setting? So what do you think? Is there a return on investment when patients are screened for unhealthy alcohol use in the primary care setting?
I mean, logically, I'd have to say, of course there is. Again, a banker. But if you can identify these kinds of problems, that this particular kind of problem early on, look at what you're avoiding, the cost avoidance, the avoidance of all the other problems you can have with alcohol abuse. So I think there's a huge cost avoidance there, which is, you know, in the end, it comes back as a return on your investment.
Yeah, I think that's some really important points that you've just made here. Absolutely. And there may be other people that may not be quite as convinced. Maybe they haven't had experience in the banking world, and so maybe think there isn't as much of a return on investments. So I think it's important to think about the other side of the coin too. What would be the risks if we don't do anything? Is there a cost to doing nothing? If a patient is receiving treatment for a chronic medical condition and the care providers suspect that the patient may consume alcohol at unhealthy levels, but don't address alcohol screening and brief intervention, might the effectiveness of the treatment plan be impacted? Does the patient with unhealthy alcohol use present more often to the practice or to the ED with symptoms? What about accidents? Lost work time? Interactions with the criminal justice system? What about the impact on family, friends, neighbors, and the community at large? There's a significant cost to doing nothing.
Let me just add, the annual cost from liver transplants alone for alcohol-related disease is well over $2 billion, and 50% of injuries and deaths in motor vehicle accidents are related to alcohol. So addressing alcohol obviously has a major return on investment.
Great point, Dr. Mark, absolutely. And it's also important to note that stigma plays a major role in delaying the provision of care because people may downplay or deny drinking if they perceive that the situation is psychologically unsafe. We no longer consider at-risk alcohol intake to be simply a behavioral choice and alcohol use disorder as a moral failing. We now understand that alcohol use disorder is a disease, and therefore we must treat it as such, which in turn will reduce stigma. Therefore, we must screen for and identify at-risk drinking and other risk factors early in care to prevent the progression of this disease. We also must address alcohol use disorder and at-risk drinking because it's an important comorbidity that we know will influence other conditions and medications. We must stop talking about alcohol relapse and instead talk about the recurrence of symptoms of this chronic disease. When framed like that and using the chronic disease model, rates of recurrence of symptoms in alcohol use disorder are analogous to those in diabetes, hypertension, and asthma. Imagine if our patients felt as comfortable coming to us for help with their alcohol use as they do for their breathing difficulties or their gout flares. I am confident that we can make this a reality. And I'm now pleased to introduce Denise O'Connell, who is the Associate Director of the Lunder-Dineen Health Education Alliance of Maine. She'll share the Lunder-Dineen Time to Ask model and Phase 1 high-level impact evaluation data. Thank you, Denise.
Thank you, Dr. Stephanie. I am happy to share that I am the clinical social worker on this interprofessional team that's speaking with you today. And I'm reminded that April is Alcohol Awareness Month, so it's really fitting that we're speaking with you, and we appreciate you taking the time today and anyone who's going to watch this recording. It's really important. So to address the problem that Dr. Stephanie just spoke about, unhealthy alcohol use, we developed a program to fill this education gap that we knew existed in primary care practices, which is where most of us receive our care, to really shift hearts and minds while supporting the interprofessional team to begin to embed what they're learning into practice. So that program is called Time to Ask, Education that Transforms Conversations About Alcohol. And these are photos that you see on the slide now of the interprofessional team at Katahdin Valley Health Centers in northern Maine, our most recent program site. So the people that participated were the front desk manager, the medical assistants, the nurses, the social workers, the prescribers, the NP, the nurse, everyone. And what you see front and center is a photo of Dr. Mark, who was presenting virtually with Dr. Stephanie about medication treatment for alcohol use disorder. And both Dr. Mark and Stephanie are longtime advisors to us and our Time to Ask program. And Dr. Mark was really the inspiration behind this program. So Maine is a rural state. Some of you may have been there or have friends or family there. We're large geographically, but small in population, and we're home to just over 1.3 million people. We have one of the oldest states in the nation and a high percentage of veterans, most of whom are older. And 94% of Mainers consider themselves to be Caucasian. Since its inception, we brought this program to 8 locations in rural Maine, and all but one practice is part of the community health center system, sometimes called the FQHCs or the federally qualified health centers. And they're depicted on this slide by the red squares. Red squares. And on deck in southern Maine, depicted by a blue square, is a more urban multi-site community health center system that we'll be going to next. And we're really excited because this center is more diverse, has many new Mainers, and we're bringing the program to them this summer. And each launch, we incorporate anything that we've learned from our prior launches using our multi-layered evaluation. So it really enhances the program for the next site. Let's examine the program model. So Time to Ask is an interprofessional and interprofessional education and quality improvement program to address unhealthy alcohol use. And our goal really wasn't to create addiction experts, but rather, how do we teach non-addiction healthcare team members to work as a team, understand why it's important to hold these routine, regular, compassionate, and effective conversations with patients so that patients really can make informed decisions about their consumption. So intervening early to prevent more costly healthcare challenges. Let's explore a few of the things that we think makes this program unique. First, Leonard-Deneen Health Education Alliance of Maine is a program of Massachusetts General Hospital in Boston. So it's bringing together two New England states, sharing rich resources both ways. Another unique feature is we're bringing together academia and practice. So we have academic partners that help us with evaluation and offer technical assistance, and one even helped us develop Module 2, which is patient scenarios. Another unique feature of our program is it's really data and stakeholder informed. So we've conducted pre-program needs assessments, ongoing evaluation that really allows us to make on-the-spot continuous improvements. And we customize and right-fit some of the program materials for each location, and we employ 21st teaching strategies. And why we're here today is our program is interprofessional. And as I said a few minutes ago, everyone participates, and you can see all the members on this slide that have participated in the program. And in doing so, we're really advancing an efficient and effective process for alcohol screening as a primary prevention intervention. One of the things that we had to do is we had to really make sure that the education was relevant for everyone of different levels of education and expertise, from the medical assistant to the prescriber. And another interesting feature about the interprofessional nature of the program is that each location creates an on-site committee, and they meet with us each month. And this committee is interprofessional. So they serve as mentors to the others, coaches to the rest of the team, and we kind of walk them through how they can examine care flow and enhance care applying what they've just learned. But in doing so, they also learn a lot about each other just from that exercise. So how does this play out in practice once the program is done? For example, first, every member of the team understands their role in supporting this work. For example, a patient arrives at the practice and a judgment-free zone is provided at reception when the patient arrives. The medical assistant who conducts the alcohol screening understands the value and better knows how to connect with the patient so they're comfortable in answering candidly and honestly. The prescriber, the provider who delivers the brief intervention does so compassionately, effectively, and then makes a warm handoff to the social worker on the team who can provide a further assessment or counseling. The scheduler understands the challenges for the patient when first accepting help and is kind and accommodating. And then also, lastly, if someone really would benefit from medication and is struggling, then the pharmacist would be consulted. So in addition to providing education and training, practice support, and access to experts, we've created the tools that you see here on this slide, and you can download those from our website. The content and format was informed by the practice sites as well as a patient advisory council, and we really applied best practices in patient teaching and literacy levels. And at our current site, we customize some of these tools for them. What you see are pocket guides for patients and providers, and posters, a manual, and we also have 2 sets of videos about little-known alcohol use facts. The newest collateral that we developed was a waiting room video, and it can play on a loop and answers the questions for the patient. Why alcohol? Why should I know? And why should I care? So let's watch it together right now. Not hearing the sound.
Okay.
you,
There we go.
there you go.
At Katahdin Valley Health Center, we care about you. Decisions that you make about your lifestyle can affect your overall health. We want to make sure that you have the right information so you can make choices that will lead to better health.
Apologize. Click something and I won't do it again.
At Katahdin Valley Health Center, we care about you. Decisions that you make about your lifestyle can affect your overall health. We want to make sure that you have the right information so you can make choices that will lead to better health. Most of us don't know the risks that come from drinking alcohol. A little known fact is that there are no safe levels of drinking. Unhealthy alcohol use can have serious impacts on your body. Unhealthy alcohol use means drinking more than suggested limits. For men, this amount is no more than 2 drinks per day, and for women, no more than 1 drink per day, with totals per week of no more than 14 drinks for men and no more than 7 drinks for women. Unhealthy alcohol use can affect anyone. You may have heard that unhealthy alcohol use can hurt your liver, but did you know it can also damage your body in many other ways you can't always see? Alcohol can cause short and long-term problems in your brain. It can affect how you feel and how you behave. It can cause trouble learning and remembering, and it can lead to poor balance and slower reaction time. It can also cause high blood pressure and hurt your heart, which can lead to heart attack and stroke. Check out the posters in the waiting room to learn more about other parts of the body and the impacts of unhealthy alcohol use on each. We also know that alcohol increases your risk for cancer of the mouth, breast, throat, liver, and colon. If you have long-term health conditions like diabetes, heart disease, or high blood pressure, drinking any amount of alcohol can make it worse. In some cases, no alcohol is recommended, like when you are pregnant, are under 21, in recovery, and more. KPHC has a new education program called Time to Ask. Your healthcare team will be asking every patient every time about alcohol use. We want you to feel comfortable sharing your drinking habits and asking questions so we can give you helpful information to make the best decisions for you. Being open and honest will help us recommend the best options. Lastly, most of us who have challenges with drinking can be helped right here at KVHC, not needing to go anywhere else. At Katahdin Valley Health Center, we are creating healthy communities, starting with you.
Thank you, Dr. Stephanie. So that mosaic of faces was a picture of Mount Katahdin. Some of you may have been there in northern Maine. But really the intention of this waiting room visit really is to kind of tee the patient up for seeing this information, starting to think about it a little bit, and really make the conversation they ultimately have with the provider less stigmatizing and more normalizing. So let's break it down and dive a little bit deeper into the actual model. We employ 3 strategies to bring the program to practices. So the first column that you see there is our education and training. The second one is practice facilitation, and the third is expert consultation. So for the education and training in the first column, we have 3 24/7 online learning modules and 1 live medication treatment workshop. Each component is assigned based on a person's role. So the scheduler is non-clinical. They would take module 1. The prescriber, the medical assistant would take all of them, for example. And that really is respectful of the time on learning that someone has to devote to this program. The module titles, you can find those on our website. Alcohol use in every day is the first one. The art and science of the conversation is the second one. And the third is really on treatment and recovery, called Addressing Unhealthy Alcohol Use in Primary Care. and that's for CME. We have a supplemental module on motivational interviewing, and then we have a 4CME medication treatment workshop as well. The second strategy we call practice facilitation and technical support, and that's really the on-site support that I talked about earlier. Over the course of 6 months, we're there with them every month, either virtually or in person, and we really work together to identify how they want to apply what they've learned. And then the third strategy is called expert consultation, where we bring in experts like Dr. Mark, Dr. Stephanie, and other people in their community that they can form stronger and greater relationships with, so that long after we're there, they've got this nice cocoon to help them continue to grow and develop this program. And we know from the evidence that you'll see on this next slide is that it takes all three to really lead to practice transformation and for the program to stick. So let's explore a little bit what we're learning, and I'll start with the pre-program needs assessment that I spoke about, and you can again download that on our website. We surveyed 3 primary care practices before we began the program to really find out what the gaps were and what their preferences were in learning and how they want to learn. And most said they want blended learning. Most said that they knew it was a problem, alcohol use, but they just felt ill-equipped to address it. Few practices had standardized approaches to screening. They felt there were barriers to collecting data and using data, and most said they really couldn't manage patients long-term in primary care. And there was a lot of misconception about what patients were going to need. So that really helped us develop the program. The next slide will tell you what we've learned from phase 1, and we continue to build on the evaluation, and we're actually working on phase 2. Where we'll have all of our data across our newer practices in aggregate with the first ones. But what we've learned is that knowledge was acquired, learners learned across professions, and across the professions, the content was well received. Also, attitudes shifted. In fact, there was a 3-fold increase in providers expressing that they now feel confident they can manage people with unhealthy alcohol use in their setting for the long term. And lastly, practice did change. So for example, enhanced screening processes, new policies and protocols where everybody's role is outlined, and there's a process for onboarding and orienting new people. And most recently, some of these new collaterals. So I hope this is helpful. Dr. Stephanie answered the question, why alcohol? Why me? Why primary care? Why interprofessional education and collaborative process? And now you're familiar with the model. So let's transition to Dr. Mark Publicker, an addiction expert who will cover best practices for engaging patients during screening and brief intervention.
Thanks, Denise. Hi. So when I began practicing medicine, actually over 40 years ago, which is actually kind of astonishing, I didn't understand that I had patients in my practice who had alcohol problems. And when I finally did, I came to realize that there was a spectrum of use. There was a large percentage who engaged in low-risk drinking. There was a fairly big percentage abstained entirely. There was a group of patients who engaged in high-risk drinking. And then there was actually a fairly small group of patients who had serious enough alcohol use problems that required intervention and referral for specialized treatment. I want to note, if you look at that, there are 40% of patients who abstain. I think if you encounter people who report abstaining, it's really important to ask why. Some people abstain because of moral or religious or concerns about their health. Other people abstain because they're in recovery. In particular, it's really important to inquire about this. Be respectful and ask patients how you can help them in caring for them in view of their recovery. This is particularly important in view of opportunities or situations in which you would need to prescribe or possibly prescribe pain medications or tranquilizing sedative medications. And let's see the next slide. And this basically expresses what our program is. It's time to ask. I have to say, initially, when I first became aware that I had patients with alcohol problems in my practice, I was very anxious about approaching them. Stephanie made the point that generally speaking, there's very little to zero education of primary care clinicians, any clinicians, in terms of alcohol use, either in medical school, residency, and certainly after residency. I was afraid that my patients were going to get angry with me and or engage in frank denial. I realized that, and what I discovered is that when I asked the patients questions in a respectful, caring manner, they responded freely and openly. So being non-judgmental and caring really goes a long way to being able to effectively talk with your patients about drinking. This is the basis of the Time to Ask program. Even brief interventions can have significant impacts on alcohol consumption of our patients. Now we're going to talk about SBIRT. Now SBIRT stands for Screening, Brief Intervention, and Referral for Treatment. It's a nationally promoted effective model for primary care clinicians. Our practices use a screening technique called audit, which is a 10-question survey that can be administered within a primary care practice. Of course, this supplements the clinical issues that may present in clinical practice. I'd just like to remind people that other than a simple screen, other than looking at it quantitatively, it's also useful to think about the questions from a qualitative standpoint. Somebody answers positively to a question about difficulty stopping, it's worth asking, what is that about? Or when somebody complains about your drinking, what is causing them, do you think? That expands your understanding of drinking rather than just dealing with it as a numerical answer. Let's look at this pocket guide that Lunder Deneen has produced, and we can brand this for the practice's location. So it gives clinicians pocket information that guides them first in explaining and educating patients about alcohol. I think there's a lot of confusion on patients and even clinicians' part about what qualifies as a standard drink. Talks about this drinker's pyramid and gives clinicians guidance to support them in their engaging in an effective intervention. And let's take a look at our next one. So let's talk about stigma. It was stigma that prevented me originally from understanding that I had alcohol patients in my practice. My belief about alcohol using patients was that I didn't have them. My patients worked, were married, had families, had jobs, didn't appear to be disheveled, homeless alcoholics, and therefore I actually did not see them. And of course, as Stephanie had said, there was no education that was provided for me. Stigma and shame are major barriers. They're barriers to patients seeking help, and they're major barriers, as had been the case with me, in terms of my comfort and knowledge about intervening and talking with my patients about their drinking. So important to realize that alcohol use disorders and substance abuse disorders in general are among the most stigmatized of diseases. It's probably even more stigmatizing than some significant psychiatric disorders, such as schizophrenia. So, not only does stigma affect how providers deal with patients, it actually affects how policymakers make treatment available for patients. And some populations have greater shame and feel greater internal stigma as well as external stigma about their drinking. Those would include women in particular, especially women who are mothers or especially pregnant women, the elderly, health professionals, and certainly people who use illicit substances are going to feel stigmatized to talk about their drinking. Let's see our next one, Stephanie. Okay, so let's think about words. What can we do about stigma? Words matter. We have to look at our words and kind of change the way that we use language. We know this in general, and we need to know it in particular when it comes to substance use disorders. If we think about what our image is when we talk about alcoholic or addict, the terms are entirely pejorative, and they condition within us negative perceptions that condition how we're going to interact with them. It's a very different factor to think about them in terms of people suffering from a terrible chronic disorder that can be devastating their lives and that of their families. Thinking about patients from that perspective motivates and mobilizes our care and our concern. A big bugaboo for me is talking about dirty urines. You know, if you think about a picture of a dirty urine, if I happen to have a bladder infection, I don't want my urologist to say I have a dirty urine. I want to have the test described to me as either negative or positive. And drug abuse sounds like a positive effort to harm oneself. Once people become addicted to substances, it's no longer a matter of choice. It's not a voluntary disorder. And we see at that point to talk about people as having active substance use disorders. Language matters. Use first person terms, which dignifies patients and qualifies them for seeking and receiving help that they need. Okay, Stephanie, where's our next one? Let's talk about recovery. It's felt that there are, in terms of alcohol use disorders alone, there are 19 million approximately Americans who meet some diagnostic criteria for some level of an alcohol use disorder. That could be from mild to severe. But it's estimated that there may be over 20 million Americans who are in solid recovery. Research has shown that alcohol use disorder, as well as other substance disorders, are as treatable and as preventable as other chronic illnesses. I think it's important to emphasize that adherence to treatment for people with alcohol use disorders has been shown to be equal to that of concurrence with patients who suffer from chronic illnesses such as diabetes and lung disease. Quite frankly, if somebody is in a formal treatment program, they're probably more likely to be adherent to treatment than most diabetics. I'll just throw in that when I began treating alcoholism back in the 1980s, the thing which struck me is I got God bless you letters after a number of months, and I never got one from a diabetic. Let's now go to this wonderful video. This is a video of an interview with Barbara. It demonstrates the elements of the art and science of the patient interview: respect, empathy, and reflective questions. And she provides the patients with information and feedback, essential elements in working with patients in pre-contemplation of their alcohol use. She doesn't create resistance. She avoids confrontation, arguing with the patient. She provides information and asks the patient herself to reflect on her behaviors related to alcohol. She encouraged collaboration, and she invites the patient to return. So let's take a look at this video. I think it's a wonderful example of an effective interview, and then we can talk about it. So let's go ahead. How are we doing?
Barbara is a 60-year-old patient visiting a new primary care provider to discuss her antidepressant medication.
Can you see the video? I'm sensing you can't.
No.
We're not starting.
Yeah,
There we go. No?
Get that little button clicked,
All right, you ready?
share.
Barbara completed the audit screening tool as part of the visit.
Thanks for filling it out. We give this form to everyone once a year, regardless of why they come in. It helps us provide better care. Is it okay if I take a look at what you put down?
Sure.
So let's see. It looks that you drink alcohol at least 4 times a week on average. And you usually have 3 to 4 drinks when you do drink.
Usually 3 drinks and glasses of wine,
Okay. That's at least 12 drinks a week.
something like that.
Okay. Just so you know, my role when we talk about alcohol use is just to share information about risk and to help patients who want help. This is different than telling them what I think they should do. I don't do that.
Okay.
What else can you tell me about your drinking?
Well, I usually drink when I'm at home trying to unwind, and I drink while I'm watching a movie, and sometimes I take a bath, but I also drink when I take a bath sometimes.
Okay. So can I share with you some information on alcohol use?
Okay.
Okay. So there has been a lot of research on alcohol use. And the guidelines we use in this country says that having 7 or more drinks per week can raise the risk of health problems for women.
7?
7.
Wow, I knew my doctor didn't like me drinking the amount that I did, but I didn't know that 7 was the limit.
Yeah, you're surprised to hear that?
Yes. What kind of health problems?
Well, things like heart disease, cancer, liver problems, stomach pains, insomnia. Unfortunately, people who drink at a risky level are more likely to be diagnosed with depression, and alcohol can make depression worse or harder to treat.
Well, that's not good news.
Well, how do you think your drinking relates to the depression you've experienced?
Well, to be honest, I drink sometimes when I'm feeling down, and I find it more interesting and not so blah.
Okay. And how do you feel after you drink?
Well, then I feel blah again.
So there are some answers on this form here. Less than monthly, you drink more than you intended to.
Yes, on occasion.
And sometimes you feel guilty after you drink.
Sometimes I just don't like how much I drink. I sometimes finish a bottle in one night.
So you're not proud of finishing a bottle.
No, it's not like I get crazy or anything, but I just don't like the amount that I'm drinking.
Right. By the way, binge drinking is defined for women as having more than 3 drinks, and there are about 5 drinks in a bottle. So you enjoy drinking wine because it helps make things a little bit more interesting when you're feeling down. But at the same time, you don't like drinking when you have more than you want it to, and then the depression returns after you drink.
Yes, sometimes I feel worse after drinking.
Where do you want to go from here? What do you want to change about your drinking habits?
Well, I don't think that I'm ready to cut down to 7 drinks a week. That seems like a lot. But I would consider cutting back to 2 drinks a night. I think that will be my goal.
If I gave you a scale from 0 to 10, 0 being not ready at all to cut back on drinking, and 10 being very ready, what number would you be at?
I'd say an 8.
Okay. Why do you think it's not something less, like a 6?
Well, I'm more ready than a 6 because I'm ready to cut back on my drinking, and I don't want to make my depression any worse.
What would help you cut back to 2 drinks?
Maybe having less wine in the house?
Having less wine in the house will help.
Yes.
What else besides drinking helps you relax and unwind in the evenings?
Well, I like to watch movies, read a book, and take a bath, but sometimes I drink when I take a bath.
So it's not just wine that helps you relax. There's reading a book, watching a movie, and taking a hot bath too.
Yes.
Okay. So it sounds like you have some reasons to cut back on drinking, and you have ways to relax besides drinking. And it sounds like you're pretty ready to cut back.
Yes.
Great. I'd be interested to see how well you do on your goal in the next few weeks. Would you be willing to come back and talk to me about it?
Sure.
Great. So let's see how well you're doing with these new meds.
Okay.
Okay, that's great. We're going to break now for a few minutes into a couple of interprofessional groups to have you discuss how you think within your own team you might be able to do interventions. Not sure how many people are there to participate in interprofessional groups, but I'd like you to think about the interview, what went on, how you yourself would respond if you were in an interview such as this, and what were the features in it that you found most helpful. So we'll take a break for 5 minutes, ask you to spend the time interacting with one another, then we'll bring you back and ask you to let us know what pearls you've arrived at. So let's start the break now.
Would you like me to send people to breakout rooms, or do you think we can have the discussion here as a small group?
Sure. I think that's fine.
I think we need to be cognizant of our timing.
Okay, so why don't we go ahead and ask people then directly without breaking into a group to perhaps share with us what they saw and what they found would be helpful. Other than Frank. Maybe we'll ask Frank to do it if necessary. Well, let me share some pearls if people are reluctant. First, one of the things which struck me is, and it's a good thing to think about, if you need to have a drink in order to achieve some state, relaxation, have a meal, socialize, it's only a matter of time until you're going to develop an alcohol problem because of the factor of tolerance. It's going over a period of time to require you to drink more in order to achieve the same state. And alcohol, as well as other substances, have the effect of actually producing the very conditions, anxiety, emotional problems that drinking is meant to solve. So that's kind of what Barbara is describing there. I'll also just point out that the clinician very skillfully asked the question about, on a scale of 1 to 10, how ready, what was she to begin to implement changes? And Barbara answered 8, and I really like the answer of the clinician who said, why not a 6, rather than ask, why not a 10? And that put the patient in a position of actually having to make the argument herself for why she needed to engage in behavior change. So there was a lot that went on in that interview. I'm sorry, this is allergy season in Vermont, in Maine, and I am suffering. So that's kind of a quick rundown. The basics of successful interviews are first a reflective manner of asking, not giving people direct questions, but soliciting reflective responses. Avoiding confrontation, which she did very skillfully. She avoided resistance. She didn't inculcate resistance. She provided feedback to Barbara and encouraged Barbara to be responsible for the change and didn't take responsibility on herself to do so. I think that there was a lot there. We can watch that video over and over again. And I want you to think about what it would be like if your primary care physician engaged with you in that way. And quite frankly, I would find it helpful if my primary care physician was doing that with my diet or blood pressure or exercise. I would find the same skills to be transferable to other parts of management of chronic illnesses. Let's go on and look at the next slide. This is very important to me. This is close to my heart. We know that there are 9 million Americans who meet diagnostic criteria for a severe alcohol use disorder, but there are fewer than 250,000 prescriptions written per year for severe alcohol use disorder. This is really striking. Try to apply that to management of diabetes without insulin or other oral medications. This is a consequence of the failures on the educational system. And from such a major public health crisis, it's really shocking. So I think it's incumbent upon all clinicians and others who support them to be aware of these medications. Almost never do I encounter people who are patients who are aware of the medications, and very often nor primary care clinicians who might otherwise encounter patients. So there is a direct role for primary care clinicians in terms of knowing which medications, how to use them, and when, and I encourage you to learn about them. Naltrexone is available both as an oral medication as a month-long injectable. So let's take a look at factors involved with management. What we do is we encourage you to think about managing people with alcohol use disorders the same way you would manage people with chronic diseases such as diabetes. You're going to bring them back. You're going to solicit information. You're going to look for destabilizing factors, especially with alcohol use disorder. It's important to recognize factors that may destabilize remission of symptoms, such as divorce, deaths in the family, job loss. I always ask about those because that gives me an opportunity to intervene, to try to identify capital that can be used by the patient, resources that they have, that they can mobilize to help maintain their sobriety. And let's finally go to the last slide. The Time to Ask program provides a platform for clinicians to educate patients about potentially unhealthy alcohol use. I want to emphasize that. The program is really designed to talk with our patients about unhealthy alcohol use, not solely to identify people who have severe alcohol use disorders. It's a very appropriate program for the primary care setting. We can educate our patients about risk. We can educate our patients about safe drinking practices. We no longer believe that patients have to hit a rock bottom. We know that primary care clinician screening and intervention can save lives. There's really nothing in medical practice that is as satisfying as being able to save somebody from devastating losses that occur with severe alcohol use disorder. And I've stayed in the practice for as long as I have because of its rewards. So I want to encourage you to consider this and use the resources that Blender, Deneen, and the Time to Ask program have developed, and look on the website for their resources. Questions? Frank?
Actually, and I know we need to wrap really quick, but I just want to give you guys, from a patient perspective, this was really eye-opening, and I can definitely say I'm really appreciative of the work you guys are doing around this, because I didn't know half of what what was being presented in there and the extent of it. What do you think, if in order to get involved in a program such as this, to get primary care physicians involved, what's a quick win for them? What's something they could attack and get some meat out of it quickly as they start down that path or journey?
Good question. Of course, our answer is our Time to Ask program, which happens to be this unique model, which is, I don't know how unique it is, but I think it's quite unique. There's nationally a movement towards screening and brief intervention. And those resources are available. Organizations such as American Academy of Family Practice and other national organizations do provide information for primary care clinicians. Be an interesting intervention with your primary care clinician. Gosh, you forgot to ask me about my drinking.
Mhm. Frank, when we're on site and we're with that interprofessional team around the table each month, before we even get to that stage, we meet with the medical director and the executive director, and we have conversations like what you just said. And what they're telling us is that they know it's a problem. It is the elephant in the room, and they feel awful about it. And we know in primary care, we've all been, right? We're all patients, and they're busy, they're stressed out, they're there because they're caring people. So what we hear from them is, this is giving us tools to address something that we know has been there, and we feel like we haven't done enough or done the right thing. So, imagine a primary care physician who has someone that really would benefit from medication, and they just didn't know about it, and they didn't know how. I'm not going to say easy because I'm not a medical provider, but when Stephanie and Dr. Mark do the in-service, they learn how to use these medications. So they've got one more thing they can offer a person.
Right.
So it's kind of getting back to that, what's the ROI? The problem's there. The numbers are crazy scary when you think about how many people.
Those numbers are crazy scary.
Right. No one knows this. We don't talk about it. And so, but they're seeing it every day, and they might be leaving at the end of the day feeling yucky. So we hope that this gives them tools to say, well, I know more now than I did yesterday. I've got a couple tools. I've got some scripts I can use, like that video. I'm gonna give it a try and hopefully feel better and change someone's life.
Great. I think we better wrap up. We are quite over. Thank you guys. This was an excellent presentation. We will make sure that we get it out.